Well, good afternoon. I hope to keep you at least with the idea that we are here to contribute, to have a dialogue, and most important, to try to answer questions that we don't have clear answers. Okay? Should children offer pancreas transplant? Sounds like a very simple thing. We know how to do it. We have the technique. We know the stitches. We know the bowel. We know the immunosuppression. But why children? We have a different question. Uh-oh. Am I okay? Okay, I always like to see where did we start it. Right. Did I do that?
I think they're drilling for oil.
This one of the most important pictures that I like is that diabetes turned a different course when we started able to synthesize insulin. And these are the landscape of what advances have been done in the therapy of diabetes, that we have to always look back and respect these pioneers that brought so much to us. Anna, where are you? You were there with the founders and the development of technique for pancreas transplant in Minnesota. That's a huge contribution that we know that this organ was able to be transplanted without any risk for the patient, most important with success. Why are we talking about that? Because diabetes has a role in civilizations, here and wherever we go. United States, the #1 cause of renal failure is diabetes. The #1 epidemic in the United States by the year 2025 is morbid obesity. 60% of population is going to be considered obese. And every time that you talk about diabetes, is there. We have to deal with this. We have to learn what can we do about it. In the day and age right now, if you talk to endocrinologists, how do we manage diabetes besides medical? Most important to tell you, we have the best right now actualized computerized glucagon insulin-based sensors and delivery treatment. So therefore, I will not send you a patient for pediatric transplant for kidney pancreas transplant. That's my center, and that's many centers I have visited. So why should we talk about it now? Let's see if we can find something. The insulin pump has changed from being a deliverer now to sensors that can even, in their literature, in the endocrinology literature, is considered artificial pancreas. So all of these therapies, as much as they do, they create some sort of euglycemia, but still we have challenges, am I right? The goals of pancreas transplantation, as we know it right now, is correct impaired glucose metabolism, prevent or stop progression of secondary diabetes, and improvement quality of life. We all agree on that, am I right? The issue is that most of our experience that we have on treating diabetes on adults. Most of our experience, we know that it takes 10 to 15 years to have renal failure in order to have in the diabetic population. So when we talk about children, that's probably not our common pathway that we're going to be dealing with pancreas transplant. So what are we going to deal with? Sorry about this one. This is the scenario that we have now for the adults. What are criteria that we do for pancreas transplant? Kidney alone on type 1 diabetes, disease donor, yes. Prevent renal failure, yes. But the best therapy that we have for diabetic nephropathy is simultaneous kidney pancreas transplant, type 1 diabetic. We know that. That's what happened. We are doing it. But how many of our patients that we see every day in children qualify here? Very few. So we're learning from the adults, but we still don't have all the answers. This surgical technique, we know it. You guys here, when you present your lectures, they're outstanding. The surgical skills to prepare this graft, to select them, to implant them, and all that, we have already all that knowledge. In my training time in the 80s, we didn't use this. We used the bladder. And we were experts on bladder, but we learned very quickly that bladder is not a good option in the long term for patients for many metabolic complications, erosion, cystitis, bladder cancer, metabolic, whatever it was not a good option, so we went to the bowel. And we learned that if you put it in the right place, the exocrine function of the pancreas can be absorbed with time. You don't have this massive diarrhea if you put it too distal. That's a very poor representation, but it is. And most important, offers an excellent treatment for patients with diabetic type 1 renal failure. So this is what we consider the standard of the surgical procedure for the type 1 diabetic patient with renal failure. I'm going to bring this slide to bring you to reality. The reality is a pancreas transplant. You have to deal with wound infections, peripancreatic abscess, thrombosis, pancreatitis, duodenal leak, rejection, and arterial aneurysm. This is the reality. What's the percentage may vary. Hopefully we're doing much better, but this is a reality, okay? And when you look at this, you're going to say, well, I'm going to do a procedure for a child But the options of complications are this one. It makes you think twice. Well, have I exhausted all the technology and non-surgical treatment for these patients? Do we have the right complications? In the adult, we know. If you have unconscious hypoglycemia, you have starting to have the nephropathy, we know when to indicate it. But in child, probably you're not going to find that. How are we going to put the complications of the procedure, the success of the procedure, based on this? Let's go one step forward. If I ask the surgeons here, what's the number one cause that predispose patients to have these surgical complications? Quality of donor, we can say that's probably in the top of the list. So, do we have a system that if you want to do a pediatric, you're going to get the right donor for the right patient at the right time? Things to think about it. Now, let's go to see what pancreas transplant doing this day. This is the latest data from SRTR, and you see that the diagnosis of this, most of them are going to be type 1. You see most of them are done. But now we have a group of population that we are thinking that we can do type 2, and we're doing type 2s for patients that are developing the same characteristics of type 1. We can see age. This is a very important slide for me. It could show that patients less than 18 years old. It's a constant number, very low, less than 100 are done in the United States. What's the problem with that graphic? If you look at all the SRTR data, nobody describes what happened in this group. Who is doing it? For what indications and what are the long-term outcomes? You can review all the literature in PubMed and all the literature in everything that you have, and we don't have a series larger than 7 patients that describe what happened in this population. So therefore, it's upon us to start looking at this and say, well, what do we really need to do? Looking at the type of graph, you will see that most of the patients that have been done is approximately 800, 700 of simultaneous kidney pancreas transplant. This is according to age. But look at the curves. If you look at the curves in the United States, what's happening? They're not going up. As a matter of fact, becoming less. Why is that? One of the questions, I'm sorry? There are a few things. One is that maybe that they're dying on the list. That's one, the disease progresses. Number 2 is that probably have better medical management. Number 3 is that we probably still very stringent with our criteria to do kidney pancreas transplant. Whatever the reason, you will hope that with the donors, when I started my career transplant in the United States, the donors were about 5,000 a year in the United States. You know how many donors we have in the United States right now? 18,000 per year. This should go up here. Things to think, why? And why we're going to talk about kids. Here we see the patients already. We want to go forward with this. These are a different type of graph, simultaneous kidney pancreas, pancreas alone. All these are showing here the percentage of them. This is one of the things that I want you to start thinking. Incidence of PTLD. PTLD is a reality in children. And what is based? On immunosuppression, EBV status, and other aspects. EBV is a reality in adults. And when you're talking about kidney pancreas transplant, you gotta think about you have to upgrade your immunosuppression to be able to prevent rejection, but at the same time, you're starting to see the PTLD. Should children with ESRD be offered pancreas transplantation? Do we have answers? Well, let's look at what information is available in the literature. Don't believe me. Let's see what is in the literature. Minnesota published their first 1,000 cases, and out of the 1,000 cases that were done in the period of time mentioned here, just 7 were children. 4 children received pancreas alone, 2 children received simultaneous kidney pancreas for a typical HUS, and 1 children received liver pancreas transplant. This data probably is not accurate completely because we're doing now pancreas transplant in multiviscerals. We're doing pancreas transplant for liver, pancreas, kidney, liver, pancreas, maybe even lung for the cystic fibrosis. So we are having more experience with it. But the only series that we have available that have seen these patients and determine what it is what we have here. Out of the patient, the outcome that were published, it is right here. 4 children received the pancreas transplant. Only 1 graft survived 4 years. 2 children that received simultaneous kidney transplants, they are more alive more than 5 years. And 1 child is alive that received the kidney pancreas, the liver pancreas. The data that we have, we can go to simultaneous single cases here and there. But for the case for today, this is as good as we have. And most important is that we had to learn that diabetic nephropathy occurs mostly in childhood and beyond childhood. Simultaneous kidney pancreas transplantation offers the best outcome. Graft quality produces the best outcome. And pediatric indication for simultaneous kidney pancreas transplants include different etiologies, including atypical HUS. Now, knowing this, going forward, what do we need to do to make this a reality for children? Let's look at what are the goals that the American Society of Diabetology and other places that look at what is the success, what are we looking in the treatment of diabetes. Most important is that the premise that we're doing this is because they say that if you have an intensive therapy and aim to lower glycemia, the result decreases rates of retinopathy, nephropathy, and neuropathy in the type 1 diabetic. That's a primordial thought that we had to think. Is this the best that we can do, that we have failed any type of technology to accomplish this? Is pancreas going to offer you that? Number two, intensive therapy of type 1 diabetes decreases fatal, non-fatal cardiovascular events. Is this something that we are concerned in the early stages of children? Probably it's not the number one cause that we would do it, but definitely has effect on the long term. All these other aspects can tell you that the pumps, right now the incidence of diabetic compensation with a new set of pumps and sensor has decreased this amount of complications. So the goal for transplantation is to allow insulin dependence, improve quality of life, and reduce secondary complications. Remember that part there. Improve quality, insulin dependence, and reduce secondary complications. So, patients in end-stage renal disease to have a kidney transplant candidate for pancreas transplantation? Yes. Is that something that is for us in children? Question two that we need to solve. Are there patients without substantial renal disease candidate for pancreas transplantation alone in this point and where we are right now? Something to consider. One of the aspects that we have so much hope that we're still looking at it is islet transplantation. Is that for us, for children with kidney disease and islet transplantation, an option? The numbers of transplants I mentioned before, they're completely getting flat and a little lower. Survival is good. We're learning already for kidney pancreas. But what we're trying to do is, what is the optimum? We have to give a good shout out for pancreas. What is pancreas does that a pump cannot do? Normal insulin response to oral intravenous glucose stimulation. Unfortunately, pumps cannot do that for us. The basal and simulated peripheral insulin concentration is 2 to 3 times higher than normal. The pancreas does that very efficiently. The pumps still to see. We all have other effects here that we can do, but most important is, what are we going to do today for adolescents? We are trying to see, we know the complications, we know how we can, the pancreas transplant, decrease it in adults, but also we have to realize that we still have to be in immunosuppression. I'm not trying to give answers today. I'm just trying to see all the points that we have to consider, to put together, to find a protocol, to find a reason why to do pancreas transplant on pediatrics. All these patients are going to be in immunosuppression. All of them are going to need induction. And most important, if you do pancreas, you gotta be ready to be able to do early diagnosis of rejection. Islet cell transplant is coming up. And if you look at the UCSF data that published last year and this year, the results are coming better. Multiple transplants are able to be done and create good graft function, and even better than this. So, to conclude, what can we learn? What can we do with pancreas transplant for pediatric patients? We want to increase the insulin secretion. We want to provide a better quality of life. We want to prevent the complications. We want to be sure that if they have renal disease, this will be the patient that we want to approach. The evolving technology of islet transplantation is still not ready, but hopefully in the next future. And most important is upon us to create trials that answer this question. We can talk here the whole day, but we don't have the data to push any way to go. But more important things, we gotta create in this group studies that answer this question. Right now, we should not be doing one here, one there. We should have a protocol to really answer this question comprehensively and that we can disperse the information. I don't have much more because I think that is a good discussion we should have here. Should we do it? What are the cases? How many have seen HUS that need both organs? what can we do different than what we're doing now? Thank you.
Thank you very much indeed, Waldo. That was a wonderful Woolstock tour. So in the last decade, we've had a couple of cases at Great Ormond Street. One we had a debate about where, in fact, because they generally are adolescents, is whether they should be managed in an adult unit that are doing SPKs more commonly, and the other is just gone off to adult care anyway. Do you think, are you happy these patients being managed in the paediatric ward if they're not akin to problems, as you've said, of having leaks, duodenal leaks, fistula formation?
I think that your team goes to both sides. I think that to make a case for just doing it in adults because they have the most experience still, it's probably a little less founded having the team going both sides. Number two, the pediatric diabetic teams in this institution, the institution is probably excellent, that this is the type of support a patient needs. I think that for me, the priority would be, first of all, is to create a system that makes sense. Who are the patients we're going to do? Number two, we need to do national decisions. This patient has to get the best donor, the best outcome that we can offer to this, because there are not going to be that many. And the third is to standardize the indication for it.
Does MD have experience of SPKs in under 18-year-olds?
I was going to ask a question actually, but my experience in Manchester with SPKs in young children was not really very good, to be honest, where there was a mortality in a child that was because of post-graft pancreatitis. But the comments I was going to just say is that, you know, in the last decade or so, the biggest kind of changes, improvements have been in our number of live donor transplants and our probably marginal or DCD grafts. Both of them don't really apply to pancreas. And even though I think it's an issue that most centers have had, that the numbers haven't climbed, in fact falling, I think the conservative approach is the safe approach. And I don't know whether you think there is a future of being aggressive or being marginal graft pancreases for transplant.
Great question. I'm sorry, Nico, you say that?
Yeah, I mean, Nizam did one in a 16-year-old in, I think it was 2006, early 2006, and she spent the next 4 to 6 months in hospital, re-laparotomies. She had rejection, lost both grafts, and subsequently she did have a kidney transplant, but she's back trying to get another kidney now, and she's yeah, she didn't do very well, basically. So that's our experience.
My experience with young recipients is that the vasculature structure are completely diseased. It doesn't have to be obstructive. It has to be the disease between the different layers. They dissect very easily. I was telling Nikos that one of my first cases was a young lady, very young woman, that was done for indication that probably they were there. They're probably not even beyond 19 years old. And the most important thing is that these vessels are so frail that she ended up dissecting both legs and amputations and long stuff. So we have to be very careful what type of procedure are we trying to do on these patients and to try to offer this technology. I think that we need to be very conscientious about creating parameters, protocols, and organ allocation for this patient.
Okay, last question from Leeds again.
Hi. Just listening to what people are saying in the room, it sounds like nobody's really got any good stories about this, and it's actually just all catastrophe after catastrophe. And so I'll pose a slightly different, is this an inappropriate procedure for a child because the surgical morbidity is so high? It's a great idea to have protocols and everything like that, but in the US you've done hardly any, so here we're going to do even less than that. You can't really develop protocols for numbers of patients that are that small because you don't really have any data to go on. So you're sort of you can make something up, but you don't know if that's going to work or not. Given that most of the renal failure is going to happen when they become an adult, should we not be looking at islet transplantation or improving the technology to get them into adulthood, and then if they're still having problems, you can consider an SPK then? Is this not an inappropriate operation for a child?
Well, I think that one thing that I'm learning, since they gave me this subject to talk about it, I have not lived but looking for cases. I worked for 3 months looking for people doing this, and essentially you can't find them. But everybody has one here and there, one there. So I think that we need to continue to look in this. One of the patients that we're not talking about, that probably tomorrow we're going to talk about, MMA patients. When they have the severe crisis early in their life, they knock out the pancreas. And they're brittle. You want brittle diabetics? Look at the MMA. So can we consider this an indication in the future when we really think about this and have guidelines to add more diagnosis? Diabetes is probably not going to be our number one, but the other things, a typical HU is a severe that thromboses everything and knock out the pancreas, kidney, and have a strokes. That patient is going to recover, but it's going to end up with a diabetes and renal failure. How can we do this? Is the full organ transplant the best option? Or islets, or what else? But we definitely need to set up a protocol, a consensus that, like a national level, to put these cases together. You guys are good friends to everybody here, not in the United States. We are very divided, but you guys can do something very good, is to put these cases together, learn from them, find commonalities, and most important, do the best for the kids.
Okay, well, thank you very much indeed, Waldo. We can have further discussions in the coffee break, over dinner, and even research breakfast tomorrow.